So we go on to our first paper, which, as the judges have opined, can be presented by Dr. AKSHAY Nair. Akshay, can you share your slide, please? Dr. AKSHAY Nair is going to present his free paper 1422, Orbital Mass as Presenting Sign of Underlying Malignancy, Clinical Pathological Features and Outcomes.
Partha, just 1 minute before he starts. I think Dr. KRS I am not seeing in the list. And there's a message from Dr. Sangeet Mittal that he would like to join late because he has a presentation in other hall. This is there in the chat.
Okay, so we will wait just about a minute. I'll call KRS sir. Pramod, can you also help me with calling KRS sir?
I'll call him. I'll call him. Yes, I'll try calling.
We will wait because we want all the judges in place so that it is a full house of judges in this session.
Sir, can you just check whether Dr. Susan Jacob is here?
I'm not seeing her also.
Yeah.
Can you, okay.
I tried calling her, so I'll try once again.
Yeah, you keep calling her because she's aware of the session. So I just wanted, yeah, Susan is joining. Susan is joining.
She's here. She's already there, sir. Just joined.
Susan, thank you very much for joining in. Dr. Susan Jacob, welcome to the judge. Welcome as the judge of the Colonel Rangachari session.
I'm happy to be here, sir.
Thank you. Thank you so much.
Thank you, Partha.
Thank you, sir. Sir, everything is nicely audible.
Yes.
We are just waiting for Dr. Ravi Shankar to join in, and then we shall start the session. If Dr. Ravi Shankar doesn't join in 2 minutes time, then we can start without him. He will not mark the first paper, and that paper's mark will go averaged for that judge, for that marking only.
I spoke to Dr. Ravi Shankar.
Oh.
He says he just needs 5 more minutes because he rescheduled his all appointments today. He says just 5 more minutes and he'll be joining if he's okay.
What we will do in that case is, I think we will go ahead because we have a large number of papers to be presented, and because it is only one judge who will not be present out of our whole series of 8 judges. So I think the first, his judging will start from the second paper, but his mark will be averaged. The mark of AKSHAY Nair will fall into the average for Dr. Ravi Shankar. Right? Akshay, is that clear with you?
Right. So basically, the average of other judges would be the score mark for him.
Yes, yes. The average of the other judges will be the score mark for you, for Dr. Ravi Shankar. Okay. So we will start, and I would request Dr. AKSHAY Nair to start his presentation.
Right. Thank you to the scientific committee. My paper is titled Orbital Mass, the Presenting Sign of Underlying Malignancy, Clinical and Pathological Features and Outcomes. None of the authors have any conflict of interest. So what is it that we already know about orbital metastasis? We know that up to 13% of all orbital tumors are metastatic in origin, and up to 5% of all cancer patients develop orbital metastasis at some point in time during the course of their disease, which is typically hematogenous in spread. Now, there have been large series that have pegged the mean survival in patients who had an orbital metastasis to be 15 months. And the duration from the initial cancer diagnosis to presenting an orbital metastasis was 52 months. But less than 15% of all orbital metastatic cases, the orbital lesion is the first presenting sign. What we don't know is how common is it in developing countries, what is the most presenting symptom, the most common primary, and the outcomes in these patients. And to assess this, our study was conceived to describe the clinical features and outcomes of patients presenting with orbital metastasis as the first sign of underlying malignancy. In our retrospective case series, we had 30 patients of orbital metastasis. However, 20 cases already had a previous diagnosis of a systemic malignancy, and 10 out of 30 had no prior history of cancer, which meant that the orbital mass was the presenting symptom. The mean follow-up for the entire cohort was 7.9 months. The most common primary was lung, followed by breast, prostate, colon, and gallbladder. The male to female ratio was 2:3, with the mean age at presenting being 68 years. The most commonest presentation was proptosis, seen in 9 out of 10, followed by diplopia, pain, and reduction in vision. Now, in the duration from the initial symptom to diagnosis was 2.2 months, initial orbital symptom. And the mean number of metastatic sites involved at time of diagnosis was 3. Surprisingly, 7 out of 10 patients had no systemic complaints pertaining to their primary malignancy, and 3 patients had non-specific complaints. 8 out of 10 underwent an incisional biopsy of the primary orbital tumor. One patient following PET-CT was found to have a primary in the abdomen and underwent a laparotomy. Another patient, a PET-CT and CSF were conclusive enough to show the breast metastasis. All patients received chemotherapy, some received radiation and or surgery for the primary tumor. And in spite of an aggressive multimodal management, 80% or 8 out of 10 died due to the disease within 5.8 months of diagnosis. A couple of index cases. This is a 52-year-old female who had a history of proptosis for 2 months with pain and diplopia. Well encapsulated, ill-defined mass with variegated appearances seen intraconally and extraconally. We did an incisional biopsy with debulking, and it was found to be a melanoma. So our working diagnosis was a primary melanoma of the orbit, and in the course of staging, we found that the primary was actually a melanoma in the rectum with disseminated metastasis, including the orbit. Similarly, this is a 67-year-old male who had diplopia, pain, and proptosis and was being treated as myocystic sarcosis. On MRI, we could see a superomedial mass with central necrosis, and the primary was an adenocarcinoma of the lung. Again, PET-CT showed disseminated metastasis all over. This is a 52-year-old female referred as a lacrimal gland tumor with a 3-month history of pain, double vision, and proptosis. An infiltrating mass into the lacrimal gland and lateral rectus along with bony erosion was seen. Incisional biopsy confirmed the origin to be breast, and you can see the primary in the breast with mets in the liver and spine. So other papers like Garrity's large series showed the mean survival in patients who've been diagnosed with orbital metastasis to be 31 months. But in our cohort, this was 5.8 months. Another series by Magliozzi, which was a huge series of 93 cases, but 1/3 had no known primary. So what's different in our patient? Here, they found no significant difference in the survival between patients who had a diagnosis of cancer before the orbital lesion versus those who presented as the orbital lesion. Same is the case with a series by Shah and colleagues, where 35% had no known primary. Again, no difference between the two groups, whether they had a diagnosis of a primary tumor or not. In our series, those who had a known diagnosis of cancer, the survival was a little over a year, but those with no known primary was significantly less at 5.8 months. And this was a very statistically significant difference. There were different imaging features seen, such as infiltrative lesions, unencapsulated lesions with bony erosion. So is there a change needed in our approach? Perhaps yes, because 93% of all patients above 40 turn out to be METs, especially if they have their following red flag features: recent onset of axial proptosis, diplopia, pain, but the classical thing is the lack of inflammation. And if you see these features, you should have a low threshold for biopsy. So to summarize, systemic malignancies presenting with orbital masses as the first symptom is common. They tend to have a poor prognosis with later presentation, which means more metastatic sites are involved. PET-CT for staging is necessary. And in patients with the red flag features of recent onset painful proptosis, diplopia, and no inflammation, there has to be a low threshold for imaging and biopsy. Treatment is usually palliative given the poor outcomes. Thank you for your time.
Thank you, Dr. Akshay. I have one question. So in your series, did you see any difference in the profile of the primary tumors in your patients, those who presented first with an orbital symptoms, vis-a-vis those who were already had a known primary?
Right. So
was the type of
internally,
different tumor different both groups?
so what was the primary tumor in case of the origin of the primary remained the same. Patterns such as lung being the most common, followed by breast, were the same or identical in both groups. Age and sex matches were also similar. So demographically, they were not different. However, morphologically, larger tumors were seen in the patients who had presented with orbital lesion as the first sign, as compared to smaller incidental lesions. And this is, I think, also because these patients already knew they had a diagnosis of a cancer. So the moment they picked up something unusual or a lump or a bump somewhere in the orbit, they immediately reported to the doctor.
Akshay, nice paper. I just had a question. You said the other series said they had the mean longevity was much longer than your series, which was roughly like 5 months. So do you think most of our patients present to us pretty late in the course of the disease? Is that the reason why this is so?
This is possibly one of the reasons. So, because one thing that is different in this data compared to all the previous series is that none of them have collated the mean number of metastatic sites involved at the time of orbital presentation.
Right.
And you can see from our series 3.3, which means every patient had at least 3 other organs involved at the time of presentation, which could probably indicate what you said, later presentation and more aggressive disease.
Thank you.
Thank you, Ale. Thank you,